You're listening to the Physio Matters Podcast, this month in association with the AOCP, and this is session 23. Welcome back to the Physio Matters Podcast with me, Jack Chew, and this month returning to the microphone as co-host is Rob Tyer. Huge thanks for the response to session 22 with Roger Kerry, which was on a topic rather close to the heart of my business and general outlook, so it's great to hear some kind words and constructive critique. This month's episode includes the first 50 minutes or so of mine and Rob's extended interview with world-renowned physiotherapist and clinical trialist, Professor Sallie Lamb. The chat was arranged by the Association of Orthopaedic Chartered Physiotherapists, the AOCP, who have kindly sponsored a two-part podcast in which we discuss some of the evidence and lack of when it comes to historic assumptions in orthopaedic practice, with a leaning significantly towards some of the Sallie's large orthopaedic randomised control trials. Many thanks before we start to Ash Shattock and Anthony Gilbert for making this podcast happen and their part in helping to make the AOCP a shining example of an open, honest, supportive organisation in which I know many of our listeners would benefit from not just becoming a member but becoming actively involved in the network. Stay tuned at the end of the podcast for a cliffhanger ending, news of an AOCP name change, details of Physio Matters discount to the AOCP conference and details of how to get involved with both Physio Matters and the AOCP in the future. But first, here's me and Rob setting the scene and David Keene introducing the podcast. We had an interesting day the other day, didn't we? We were driving on down to Oxford to interview a rather big name.
Yeah, definitely a heavyweight in the field.
Yeah, well, I'll tell you what was something I thought would be useful to just chat about before we even expose the listeners to the episode. It was a bit different, really, to what we'd normally do in terms of the preamble and the workup that we usually put behind a podcast. One of us usually does more behind the scenes. Incredible job that the AOCP did, namely David Keene bridging the gap. But because Sallie's so busy and her time is so precious, that the normal process that we'd go through where we'd speak to someone and then lay out the questions off the back of that conversation and have those questions looked at, and this is something that we just weren't able to do because the only time that could be afforded was for the recording. So that presented some fresh challenges in conversation, didn't it?
Yeah, it definitely did. And they did do a great job sort of juggling contact between all people involved. Just made for an interesting dynamic when we got there as to maybe dusting off a bit more journalistic skills that rather than having a polite chat at the start, a bit of feeling out of whose defensive area we're in and whose attacking area we're in. If you want to use a martial arts
typical
analogy.
You to get the martial arts analogies in there. No, it certainly was a fresh challenge. I think naturally in conversation you have to ease into it in order to be polite, but it was probably, and I know full well it's the first time that a guest wasn't aware of our work. I mean, I don't know if that's some arrogance on our part, accidental arrogance on our part, but our somewhat popularity across certain areas means that people that come on the show know the show. They know the drill, they know the style of questioning, they know what's come before. Whereas certainly not the case here.
Yeah, I think the shoe was on the other foot, really, wasn't it? In this episode, we basically knew quite a lot about Sallie's work from our bit of digging and research that we did, and she didn't know much about us, which was interesting.
Yeah, and I think as well we feel like we knew about her off the back of academic pieces, but I mean, we'd not heard a lecture before, had we? Or
no, not at all.
Not someone that's on social media, for example. So that, again, just fresh journalistic variables for us. So learning curve all round.
Definitely, yeah. I must say we had the recording done prior to the debate that she held with Roger Kerry. So it was, we didn't even have that, even though that was flying around social media quite quickly after we did the recording. Despite
the fact that we had to ease into the episode and it might be somewhat slower and gentler in its introduction than our usual ones, we didn't succumb to any fooling about, though, did we?
Sallie and David certainly made us feel very welcome. It was definitely evident that Sallie's a very busy person. I think she had some pressing matters to get on with after the recording, so there was no time for messing around with, daft sound effects or anything like that.
Oh yeah, of course. Yeah, we wouldn't want to be doing that, would we?
That's highly unprofessional, I would say.
For sure. Yeah. Well, okay, let's be as vehemently serious as we usually are and get cracking with this episode, then, mate. I think me and you can reconvene. I think we've both had a chance to have a listen to the edit now, so let's have another chat after we've put the episode out there and reflect on a few things.
Yeah, I think that'd be a good idea.
Cool. I'll speak to you in, about an hour?
Yeah, look forward to it.
Hi David, would you do the honours of introducing us to the context around why we're here today and about to interview Professor Sallie Lamb?
Oh yes, my name is David Keene. I'm a research physiotherapist, postdoctoral in the university, and I work with Professor Lamb, and I'm a newcomer to the AOCP committee, and I've taken up the research lead there. And part of the agenda of the committee, and I have to say this was set up on the hard work of my colleagues on the committee rather than myself, so it's, they should perhaps...
You're here for the glory, but
that's it, I'll take the glory.
Definitely thank them for their work behind the scenes, phenomenal.
So really I just took on the link person because I work with Professor Sallie Lamb, who's quite an international leader in clinical trials and research in the field of orthopaedics and trauma. And so we thought she would be a good person, particularly with her broad range of trials and interaction with guidelines and committees that fund research and with professional bodies to interview about the general issues facing our profession in this area, some of the issues about evidence-based practice, and promoting evidence-based practice and innovation are big priorities for the AOCP committee and us as an organisation. And I think it's fair to say that we're recognising that traditional avenues of dissemination of practice change, CPD, it's shifting, and your podcast has been one of the avenues which has been able to get great topics covered at great detail and give people some quality CPD. So that's why the ACP wanted to sponsor a podcast with someone like Sallie.
Fantastic, and it is a huge honour for us to be here and a huge honour for the AOCP to even recognise us as an educational medium. As far as the topics considered, I thank the AOCP for giving us a scope and a broad sort of approach that we're allowed to pursue, because it could have been very particular, very niche, and we could have been parked in front of a fracture off specialist surgeon, but instead we got such an eminent thinker in the field of evidence-based medicine, and we're hopefully going to engage in an interview in a second with Sallie that is far-reaching across 2 episodes, so thanks again for that.
You're welcome.
Okay, so we're here today at the Botnell Research Facility in Oxford with Professor Sallie Lamb. Without me rambling with an introduction, I'd rather hear it from yourself. So could you introduce yourself for the listeners, please?
Yep. Hi, I'm Sallie Lamb. I'm Professor of Rehabilitation here at the University of Oxford, and I'm also the Director of the Oxford Clinical Trials Research Unit.
Okay, fantastic. And so could you tell us a little bit about your career journey to date and what's led to this moment?
Yeah, sure. I qualified as a physiotherapist in the very end stage of the diploma days, so I don't have a first degree in physiotherapy, and I was left with a sense when I trained of not really being sure that many of the things that we were doing were evidence-based, and at that time evidence-based practice was only really beginning to emerge in its rudimentary form. But I found as I went into clinical practice that, as many physiotherapists will have found, that I was regularly asked what the evidence was for the type of treatments that we were providing. And slowly over time, I just began to question more myself what the evidence was, and I began therefore to pursue a training in research methods alongside a clinical career. So I worked clinically for about the first 10 years of my career. I also had a short stint in the rather old-fashioned teaching of some of the old physio schools, which also left me with questions about where the future of physiotherapy was going to be.
Okay, so it was born out of a clinical frustration, can we say, in the fact that we were left without obvious answers on certain topics. Was that then why your research now is on a variety of different topics, quite a broad area, or did it start specific and become so?
I think that the reason that my research is reasonably broad is that in the journey of becoming a researcher, when I did my first master's degree in rehabilitation, I realised actually that I was quite numerate, and so I did really well in the statistics module. You know, I'd always been told at school that I was no good at maths and all of those types of things. And suddenly, you know, I was top of the class. I'm like, whoa, what's happened here? And I made some discoveries about myself, as you do when you learn. I just made these discoveries about myself. And that took me on a different journey. I think sometimes, you know, physios have so many skills that they don't realise they have. And I took a journey with this skill, and I became a statistician, an applied type of statistician, and it led me to a career in clinical trials. And I have combined that career trajectory of being a clinical trialist and applied statistician with my love and knowledge of our clinical area. So I've ended up working across a very broad range of different conditions, both within musculoskeletal fields, within physiotherapy, but also much more broadly. So, for instance, I support people who do work in cancer trials, gastroenterology trials, you know, really lots of different types of trials.
Okay, and so I dare say if you were to wear a badge, it would have an awful lot of titles underneath it in some ways. What would you consider yourself now? Would you say a physiotherapist, or would you consider yourself a clinical trialist?
I'm not a big one for badges and labels, actually, and I try not... I don't personally label myself, so I'm label-free, I hope. Fantastic.
No, it's a great answer, and it's certainly one that's in keeping with a number of our other guests have said as much, and that's the adequate blurring of the lines that's occurring between professions and also within our own profession. So that's fantastic. Now, we've been introduced by the AOCP, and so we're here today to do a special two-part podcast, and my colleague Rob Tyer, also a fellow member of the AOCP. So together we're going to try and explore some of the long-assumed foundations of trauma and orthopaedic practice with a slant towards your research work. And mainly because it does seem like an area that is littered with some assumption, and so from that hopefully will be born a discussion around the future of evidence-based practice and where we might be going with that. And so regarding evidence-based practice, how it's constructed and integrated into practice, do you feel the patient is at the centre of that, or do you feel that realistically we are having research questions born out of laboratory-based issue?
The patient is one of the things that is at the centre of the research that I do, or of the research world that I'm in. Patient's clearly really important. But actually, I don't think the research questions for me are born of the laboratory necessarily. They're born much more of society and how society wants to invest money in its health service, what society needs in terms of evidence to inform how it makes investment. I mean, we have a socialised medical system. It has a finite boundary, as in fact any health system has. It's just how big the boundary is, and choices have to be made. So, to me, the centering of my type of research is maximising the patient outcome and minimising the impact on the public purse. So, really getting the most efficient type of interventions developed, tested and evidenced.
Brilliant. So that's a societal need that's driven.
Yeah.
Do you think that at this moment in time, if we were to freeze frame, do you think that the formulation of evidence and then the dissemination into what that means in clinical practice, are we particularly successful of that at the moment?
I think we are very aware, both as researchers and as members of research community, of the really large gap between research and practice. And of course that we're probably at the closest point. Our research group is very much at the point of developing interventions for testing in pragmatic settings. So we are looking for everyday settings, and we run large multi-centre studies because we're trying to show what's the value of treatments in the real NHS. And as a consequence, we end up implementing new interventions, often at substantial scale, into the NHS. So as part of our research process, we learn about implementation. We also have to work with therapists who are in the everyday setting and trying to do this in and amongst their normal working day. Even despite that, and despite our commitment to developing interventions that can be implemented into clinical practice, that process of implementation is slow and it's difficult to do at scale. And we know, for instance, that the average time between an intervention having a really good, solid research base, for instance, in a large-scale trial, and getting into clinical practice is about 17 years. Now, that's not physiotherapy-specific information. That's just the general time frame. And that time frame has to decrease. It just has to get smaller, and there's lots of tricky questions there, but we're now working really hard to make sure that we're working on an implementation agenda as well, trying to pull that time gap down.
Do you think that historically research has been disseminated from an academic journal point of view, and some of the barriers that some clinicians may face would be the cost implications of accessing some of those journal articles? And, in the dawning of the, social media and the internet, where we've never had so much access to information, how do you see that impacting on that 17-year waiting period to implement research into practice?
I think that the issue about access to journals is getting better. So many of the journals are now open access, and the biggest journals, actually, journals like The Lancet, are really substantially committed to open access. So open access means that journal articles are available free, downloaded over the internet. But I think as a culture, physiotherapists in clinical practice are not used to kind of demanding that they should have access to the internet, that they should have the ability to be able to walk into the back room where I know everyone has a cup of tea and be able to access a computer and kind of download or track what's coming out in the Lancet, or follow things like Musculoskeletal Health and see what's coming out new. We need to be saying that this is an important part of how we practice, and we need to be pushing that agenda so those facilities are available to people. And I haven't been in the clinical setting very recently, but what I do notice is actually it's not changed that much over the time since I've trained. It's not changed much.
Yeah, and I think obviously that's exactly what we're doing here today, and trying to get that message out there. With regards to just to bring it back to the trials and the multi-centred nature of your trials, it's fairly consistent throughout your particularly big pieces of work. Now, once that multi-centred trial has then ceased, the centres that were involved in that, I imagine it's fairly, I don't say simple, but more straightforward to, at least for those, to then take the research findings and then integrate them because they were integral to the workings of it. They feel that there's some ownership to it. Outside of that, does it disseminate beyond?
It's not a straightforward answer, and we do track what happens in our centres after we've finished a multi-centre trial. So, for instance, we have a study called the Back Skills Training trial, where we developed a cognitive behavioural approach for physiotherapists to use, where we're targeting physical activity as a way of alleviating low back pain. We're using cognitive behavioural principles to do that, and we in the original trial we trained people on a 1.5 to 2 day training, and they had to make some kind of what might not seem like massive changes to their practice, but actually are quite large cultural and organisational barriers. And that was that they had to deliver the intervention in groups, and groups move in and out of fashion in physiotherapy. And there's all types of complexities around that, about the identity of what a professional is, and whether or not you deliver stuff in groups, and whether or not you deliver stuff related to a protocol. And then there's actually the logistical difficulties of changing the diary system in a department to ensure that you can, kind of get all these patients together in one place at one time. So we have found that some of our departments have gone on to keep those changes when we've implemented them within trials. And some departments just do it for the trial, and then they will go away and they'll take little bits and pieces out of it, but they'll kind of change back to where they were before. And sometimes in trials as well, we have to, in order to be able to deliver the volume of care, we have to kind of commission specifically some of these types of groups outside of the NHS. So, some of them are run in the community. We've just run a big trial of dementia, high-intensity exercise training in dementia, and that was extremely difficult. And in the end, I had to employ physiotherapists to deliver it in community settings, just to kind of get the trial done. The key things that we found out about implementation is helping people to access the intervention in a way in which they can actually assimilate it and use it and learn the skills, but also to learn all of the other things around it. So how they have to change how they think about things in order to be able to implement things in their practice. It's not just a matter of saying, right, there you are, just do that. People have to go on a journey themselves to change things. And now what we're doing with almost all of our trials, it's not quite all of them because we don't have capacity, we are now progressing on to have an implementation study and bespoke, for instance, internet training available to people with the help of the Oxford Clark and the National Institute of Health Research to try and overcome this difficulty. And that's an area that we've expanded into. And in the next year or two, it will be available for people to log into and to access interventions in a different way.
I mean, that's fantastic. Really looking forward to seeing that take shape. I do fear that we're being awfully polite on the fact that change we know comes slowly. However, there is some reluctance or aversion to change for a variety of reasons on the clinical frontline. Now, I'm not suggesting you should answer that being in the research thing, but however, is that a frustration for this information to be out there, for the multi-centred approach, for the dissemination streams that you're describing, yet it takes so long that by the time it's integrated, it's dated?
It is a frustration. I'm probably a little more sanguine about it than some of my colleagues who work more closely with me. I know they find it really frustrating, and this is a reason why we have gone into this implementation area, because people were saying to me, I've been in and around research for a long time, and after a while you get a little bit cynical and you become accepting of a situation. But my colleagues were saying to me, look, this is really frustrating. Why isn't this getting into practice? We should be doing something. You should be out there doing, getting this into practice. Well, that's not easy, because the problem is I'm employed to do research, and I'm employed to do that by a research organisation that expects me to perform at the very highest standard of research activity. And therefore, it's difficult to scale up implementation. But yes, it is frustrating, and we've answered this frustration by securing the funding to be able to do this implementation work and to really now push that forwards. And it's going to be very interesting to see how our clinical colleagues respond to that. So we'll start with the back skills training intervention, and then very soon after that we'll be looking at how we implement the SARA training, which is strengthening and stretching for rheumatoid arthritis of the hand. And we just prioritise really based on how useful the clinical intervention is, but there's some other questions that I think we should think about in terms of implementation, which I'm sure you'll ask me about in a bit, which is following on from the managing injury of the neck trial, where actually we showed overall that it's not really value for money for the NHS to invest a lot of money in the management of acute whiplash injuries. And that is actually more of a challenge to our profession, because we're not asking people to do new things, we're asking people to stop doing old things. And that's where the maturity of a profession really becomes evidenced. And I really want to encourage people to think about, we operate in this fixed kind of financial envelope. The only way we can start to do new innovations and bring new things to patients is by leaving behind some of the old things that aren't worth doing. And I think if people could really grasp that instead of being threatened by it, we will make faster progress. We will serve our profession better. But, that's easy for me to say. I don't
need to be met halfway. If we dare call that a top-down dissimulation, there's got to be some meeting in the middle by clinicians with a willingness to integrate, or a willingness to have that conversation.
And I do think that, I go to the Chartered Society of Physiotherapy Congress and I meet many clinicians. And those clinicians that I meet there are generally very keen. I mean, maybe I'm seeing a kind of particular subset of people, but I think generally it's a very hard environment to work in the NHS. There's a lot of very enthusiastic people who go into physiotherapy, and I think it's a challenge for them to maintain their enthusiasm. I think some people do it. They remain incredibly committed to being positive and to changing and to engaging with research and development. I think a difficulty we face is that as a whole, it's tough working in the NHS, and the thought of change, I can understand completely why the thought of change is just, I can see why people just think, I don't want to do that. I just want to go into work, do what I do, which is the old stuff, and go home and not think about it anymore. I can kind of understand that, but we've got to keep our profession up, and we've got to keep the energy and the enthusiasm and the commitment to changing, because that's how our profession will flourish in the future. And I think we get talented people in, and we have to fight hard to have our talents recognised, and research is a really important vehicle to do that.
Do you feel that, with a large proportion of your research being in the trauma and orthopaedic setting, which I hope is fair to say, and I'm not making any assumptions on that, just we've done a little bit of reading about some of the papers you've published. Working as a physio, historically, the orthopaedic setting has been something that has had maybe a hierarchical system, whereby physiotherapists maybe do as they're told, as opposed to sort of in fulfilling their autonomous practitioner role that we're constantly reminded about in day-to-day practice. Have you seen this sort of hierarchical system within research? One thing that I should probably clarify on is not necessarily this sort of somebody at the top governing the direction of the research, because you mentioned that you want people, and I'm sure we share this belief, that we want physios to be more involved in research, but research is difficult and clinical practice is time consuming. Is there a role for physios as autonomous practitioners to express their expertise in areas of research, or do you feel like we're not there yet in terms of physios being able to do that?
No, we definitely are there, but I think that we don't realise it, and I think that it takes more than one person to break out, as it were. So as I see it, there's two physiotherapy research communities. There's a community of people who research within physiotherapy, and they stay within a community of physiotherapists. And so I'll just say they stay within a community of physiotherapists. And I think that's the majority of academic physiotherapy. And then there's another world outside of this kind of bubble, which is the broader health research community. And this is a community in which we really have to engage. And there are more people breaking through and being successful in that community And I think that is really important because that's where the hierarchy gets broken down. So when I talk to a surgical colleague, I mean, and my colleagues here are professors, no, very eminent professors. Fortunately, you know, they're also learned and insightful. But when I talk to them, it's as an equal peer. You have to recognise what we can bring to the table that's unique and strong. And what we really bring to the table that's unique and strong is our understanding of how people function and how disability evidence itself and how, you know, the relationship between impairments and disability. This is not a field that many of our other colleagues are really used to. So, for instance, many of the medical type of colleagues that I interface with are used to using mortality as an outcome. They focusing, you know, kind of all of their effort on saving lives. And that is, you know, that's a very good thing to focus your effort on. But increasingly, our problem is on people with chronic health problems who have chronic disability. And it may be, you know, kind of low-grade mobility problems. They're the most common of all problems that exist in the population, and those are fundamentally important. And if we don't appreciate as a profession that the knowledge we have, the knowledge we can bring from clinical practice into science is valuable, that's a poor place for us to be. And I would be sad, actually, if that were the case. We should just feel a lot more confident about it. We bring so much to the table. I think what we lack is confidence.
Fantastic. In the realms of orthopaedic practice or trauma orthopaedic practice, just to try and think of a flip side, is if a physiotherapist was leading a trial, sort of someone even of your standing was to lead a trial on, say, operative versus non-operative care, essentially then our orthopaedic surgical colleagues would feel that is too bottom up, and that fundamentally it's easier to talk about than to do, because the burden lies with orthopaedics in terms of they're the ones that need to do the surgery, they're the ones that need to make that binary decision, yes or no. And so that's where I find a bit of a kickback from orthopaedic surgeons, is the idea that really that's why they should be leading and governing that style of research.
I'm senior author on the BMJ paper. The person who led the trial was Damien Griffin, who's an orthopaedic surgeon. So in my world, it's perfectly fine that the skills I bring, both in terms of statistics and sometimes in terms of clinical practice, would be at what might be perceived as a more senior level than actually some of my orthopaedic colleagues. So very regularly, my job is to help orthopaedic surgeons to think better about the questions that they ask. And I bring all my experience as a physiotherapist to that. You know, I try to help them to choose the right outcome measures. I think that's a very important place where we have an input, you know, so we're guiding about what's a really good outcome, how big a change should we see, what's really helpful to patients. And of course, you know, a surgeon's very much focused on a procedure. Here in Oxford, in the trauma service, you know, kind of the post-operative care and rehabilitation is, once the operation is over, the surgeon really isn't involved in the care. If something goes wrong with the metalwork, they're there, but they leave it to us then to deal with. So we bring, you know, kind of like, we're empowered with that responsibility, and I think that's very common.
Do you think in the future it could be flipped? So say, would you be lead author on that paper?
Yeah.
Or would that be wrong way around?
No.
Because it's completely within the realms of equal peers, as you said before?
Yeah.
Brilliant. In terms of some of particularly the lower limb studies, we want to just explore somewhat non-specifically about the idea of weight-bearing status following traumatic and atraumatic lower limb injuries. On what framework are some of these decisions made, and is the reasoning supported by evidence greater than historical anecdote? Because without going into the specifics, it does seem that there's a lot of arbitrary numbers that get plucked with regards to how long someone might be weight-bearing or non-weight-bearing.
Yep. So the first disclaimer I will make is that this isn't my area. This is not my area of research or knowledge expertise. But my observation is that I think that the basis is quite old. I think it probably comes down to some very historical work on tissue compliance, mechanobiology. And over the years, those principles are kind of subsumed within the fabric of clinical practice, surgical practice and physiotherapy practice. And they're never updated or challenged. Kind of techniques change, but that kind of underlying physiological principle stuff, I don't think really kind of gets changed. And what was interesting, it was really fascinating when we did the collaborative ankle support trial. We tested 4 different types of bracing for severe ankle sprains. We tested a short 10-day cast, and we tested various other braces that cost different amounts of money and give different amounts of stabilisation to an ankle. One of them being, kind of a fancy boot that really costs quite a lot of money. And I think at the outset of this trial, we had assumed that fancy boot that costs quite a lot of money, of course, delivers better outcome. Now, I was bowled over when the 10-day cast actually emerged as the most effective treatment, because that really goes against our kind of principles and our beliefs about how tissue healing occurs. And it made me stop and think about, well, kind of what are the assumptions about the biology that we're making here, and just rolling over from one thing to another, and kind of not really questioning why we do things.
And it was nice to see several arms of a study investigating not only the effectiveness but the cost implications of applying something like a tubey grip, a plaster of Paris cast for 10 days, an air cast boot, and the super snazzy expensive boot that was put into there as well. And it's interesting you say that we haven't moved on from some of the historical thoughts behind tissue microbiology. There's an emerging world of mechanotransduction whereby a lot of physios are being pushed towards actually loading a tissue within its tolerable stress in order to encourage the formation of tissue regeneration. And it wasn't so long ago that we were still asking people with back pain to bed rest for 2 weeks. So things are changing, but they do take time. But I wonder, would your thoughts be that, yes, from a cost effectiveness and a clinical effectiveness point of view, the 10-day casting was very good, but how does that differ in terms of some of the other features that may be implicated with immobilising someone who maybe has the potential to develop a secondary fear avoidance or a catastrophisation of weight bearing, or being put in a cast, which is often reserved for those who've had a significant trauma, as opposed to then putting a tubey grip on and encouraging that person to load bear with tolerance, with, say, a pair of elbow crutches?
I think that when you read a piece of research, you have to look at what the outcome measures are and what they provide to you in terms of information. We don't measure every single possible kind of adverse outcome. We measure if something catastrophic goes wrong, and we measure, we keep a capture of adverse events. But for instance, in that study, we didn't measure catastrophising or fear avoidance. But what we do measure, of course, is the function of the ankle and the leg, and we measure overall health-related quality of life. And it would be really implausible that those variables would not reflect some kind of problem with a treatment, whether it be catastrophising, whatever it be. All of those signals, both at the kind of level of the leg and the level of the whole person, told us that actually this 10-day cast, you don't need to worry about it. The patients who don't want it, don't let you put it on it. And the patients who have it, mostly keep it on. and they're happy enough with it because actually it reduces their pain. They haven't got a brace on another foot, but they were happy with the treatment that they got, and overall it afforded them a better outcome. It was quicker, and I think it's the advice that I would take from it as a physiotherapist is that when I'm with a patient, I should be discussing with them, okay, look, there is this evidence now, and it was very controversial. I mean, it was boo-hooed in every possible place. I had the Germans on. I had a communication from Germany that was just bizarre over. It's outrageous. Outrageous. Well, it's not outrageous. It's a really well-designed piece of legitimate research, and there is your answer. I don't have any invested interest here in saying that this plaster, fibre kind of casting, is any. I have no vested interest.
You don't have any shares in
that is the result of a well-conducted randomised controlled trial. Just stop and think. Think about offering it to patients because it speeds up the outcome for them. And then they can make a decision along with the therapist about whether or not it's right for them.
Can we look at that trial a little bit through a particular lens, not necessarily statistically?
I hope I can remember it.
Well, sorry. But when we come to looking at the interesting inclusion of the fact that the patients were randomised as having severe ankle sprain, and the way in which that part of the inclusion criteria was that been non-weight bearing for 3 days. And so then...
So it wasn't that they were sent away and told you're not to weight bearing.
It was... I didn't state that very well, is that as part of the inclusion for when they then entered into one of the trial arms. So if I was to simplify it to, let's go tubular bandage versus the 10-day cast, is that part of the one of the variables that I'm just trying to consider here is that the action of the inclusion criteria being that they were non-weight bearing or struggling to weight bear over the course of 3 days, the fact that they were then through a robust trial methodology were to then be put into a 10-day cast arm, that then they've self-selected that as a preferential treatment in that they've voluntarily non-weight bared, they've not been told to, they've recognised personally that that's something that they think is going to be to the betterment of their recovery. If they then were to be categorised into that over tubular bandage, might that be a variable that's hard to control for?
What we try to do when we design a trial is we try to reflect as best we can, because we can't always do this, the realities of how this kind of injury and pathway occurs in normal practice and what happens. So the way this injury evolves is that, you're out on the football pitch, you crack your ankle, you come up to the emergency department. Your ankle's like this big. Listeners can't see, but it's like a balloon. And you're in the ED department and you can't quite see what this injury is. So you might have an X-ray, you may not do because they applied the Ottawa rules. It was up to the emergency departments to do that. But then it's common for them to allow the swelling to resolve before they would apply a cast. So they wouldn't apply a cast then. And the thing that happens is that they generally, and we did this through a national survey, would apply a tubing grip and just let the injury settle a little bit before they casted it. So that's one thing that led into how we designed this trial. The other thing is that we were not interested in having people who just had a minor sprain. This was a study about severe ankle sprains. People with minor sprains get better. It's the people with the severe sprains. And of course, you can't really diagnose it very accurately when they present in a hyperacute state. It takes a little bit of time for some of that to resolve. And the way that the inclusion and exclusion criteria work for the CAST trial is very pragmatic. If you were to come back at 3 days and your swelling had resolved, so, we get all comers. We're not selecting people, these are all comers. And they may come with a little bit of swelling or a lot of swelling, but if they came back at 3 days and they could quite clearly walk up and, across the cubicle and back again, well, they haven't got a they haven't got a severe sprain. So it's just kind of like it's a method. That 3-day window allowed us, A, to put on an emergency treatment that was standard across all the arms, and B, just to ensure that we got the severe sprains, because we're not really that interested. And we feel that it reflects clinical practice. And people have kind of gone, oh, well, if you had applied the boot or you'd applied this at that time, these results would be different.
Yeah, that's nitpicking.
It's nitpicking.
Okay.
They don't like the results. They're just trying to find a way to unravel the results so that it's kind of it says what they want to do. I think people should just look and make their own judgment about whether they think that the approach of just that application of tubing grip or a back slap, for instance, that's commonly used, before you kind of go in to choose your final treatment, and for us to be able to ensure that this was a severe injury is fair or not. There's lots of organisations that will make their decision, and in fact have. So people came back and nitpick it around this issue. They also nitpick quite a lot around thromboprophylaxis, but that's the Germans and some of our European colleagues, nitpicking around these areas. But I think that what happens over time and what we've seen with that study is that as guideline groups have looked at this and people have looked at it in a more sensible, kind of collective type of way, then they have kind of said, yes, actually, this evidence is fair and it's appropriate. It was a well-designed study. Those difficulties that you have to accommodate in any trial, of trying to reflect every day, were fair, and we feel it's generalisable evidence, and that has now happened. But that's, of course, I'm going to say, yes, I think, we designed the trial as best we could. It actually takes an external body like NICE or an international guideline panel or a national guideline panel to take the evidence and appraise it, and that's some of the waiting game that happens.
Yeah, and we've got to have faith in those procedures, absolutely. Interesting that the term severe is based on the symptomology. It's not radiologically severe, or
nope.
it's not deemed. It's deemed and defined by the patient, which does get born this question over what type of person is considering it severe and why their symptoms are.
Well, the criteria was your weight-bearing status. So it's not that we kind of said, oh, you must be non-weight-bearing when you came the first time, and hence you're non-weight-bearing when you came the second. This is a test to see how well a person can bear any weight through that limb, and it's a good proxy for how severe the injury is. It's not a great proxy on attendance number 1, but it is a good proxy on attendance number 3, day 3. Mm-hmm. And that's what we use. It's simple, it's pragmatic, and we must remember that, radiologically you can't tell how severe the sprain is. I know you can see some bony issues, but actually the soft tissue stuff you can't see. And very often in ED departments, it's not physios who are dealing with this injury, it's nurses and the specialist nurses that are down in the ED, and these are common ways in which they practice.
And so if I wind it back to my initial sort of awkwardly worded question over if someone walks in on day 3, hobbles in with reluctance to weight bear, might that, if there were to be separated into the cast arm of that trial, that be in keeping with their values and what they think?
So no patient ever goes into a trial unless they want to. So we explain to them before we randomise them, so we don't kind of put them in an arm. They get put into the arm on a chance basis. But all of the 4 treatments are explained to the patient. And we say, are you willing to be randomised, to take a chance here, and to recognise that actually you may not, if you do have a preference, you may not get the treatment that you want. And people are generally very happy to do that. Not all people do. They don't actually, and we do collect reasons why people don't want to go into trials. It varies by trial, of course, because, it depends what you're offering. It depends what people think about it. But also there's other things like they don't want to fill the questionnaires in over the next 9 months. These are young people who are playing football. They don't want to be chased around by us. They're not all actually young. This is one thing we did learn. We learned quite a lot about ankle sprains in older people, actually. But no patient is ever has to compromise themselves in that way. And the other thing that happens in these trials is that we randomly offer these treatments. And of course, not all patients will actually have the cast on. And you can see that in our data. I think there was a proportion of people who, even though they said they would be happy to be randomised, then was not happy to have the cast. They clearly had in their mind that they wanted something else. But we kind of say, right, we had intended to treat them with a cast, hence we keep them in that treatment arm, and what we end up with is a conservative estimate of the treatment effect, because it includes both compliers and non-compliers with the treatment across all of the arms. And in that trial, we can measure compliance with the plaster cast really quite well, but of course what we can't do is measure compliance with the brace. We all know people can take them home and leave them on the side. So we just have to go forwards and measure their outcome. So for this trial, what I would say is that the decision on severity comes from two places. It comes from the patient, what they say. Assessment is done by a physiotherapist for the entry criteria to the trial. So at day 3, they come back and they're seen by a physiotherapist, a research physiotherapist from the trial. And they go through a set number of procedures and questions and then make a judgment based on our guidance about how to kind of make a judgment related to those questions about whether or not this patient is a candidate for the trial or not.
That's great. And was in that particular trial, interestingly, the 9-month data suggested very little difference between groups.
Yeah.
So that opens a further can of worms. If I was to reduce it, apologies for doing so, to say tubular bandage versus cast, and at 3 months there was a superiority to 10-day casting. Therefore, in clinical practice, does that then? I feel I get burdened then with the question that if I was working in ED, I feel like I'm having to think about that person's need for function over 9 months before I then cast them immediately. If there's no difference and they would prefer to not be cast, then essentially I can reassure them on the fact that actually they do regress to the mean.
Yeah, I think there's a few insights that I'll make from the cast data. The recovery was quicker with the 10-day cast. At 9 months, you ended up in no different a place. To some people, the speed of recovery is very important, and to other people, it's not. And that's a discussion that the clinician has to have when they try to use this evidence in a consultation. So my sense is that what people should be doing is we shouldn't be saying, of course, everyone has to have a cast. That's crazy. But it is, I think we're obliged to say to people, if the speed at which you recover is important to you and you're willing to consider a cast, then this is only a short time period, and we know that it will speed things up for you.
Yeah, and it informs clinical reasoning over a blanket decision that needs to be made across the board regardless of functional need, is what we're saying.
That's my take. Of course, my take is not necessarily the same take as a guideline panel might have. And I'm sure that probably a guideline panel would say something that, like, it's recommended that patients consider a 10-day cast. Perhaps the more important thing to think here is I think the casting thing is it's interesting.
Definitely.
And I think it's interesting from a number of levels. A, it was entirely unexpected. B, it challenges our assumptions about the kind of mechanical biology of early recovery of injuries. That is really interesting. And C, it kind of gives a cheap treatment that gives you a greater speed of recovery. That's, it's unequivocal. It's in the data. But the more important thing, perhaps, is to realise that the more expensive treatments, which ED were using, are not worth the money. So I would be very surprised now if there's EDs who are giving fancy boots at £200 a shot out to people who have got a severe ankle sprain. So, the evidence gets used from lots of different angles, and we're focusing on one angle, and we mustn't forget the bigger picture.
And that's a great point. And when scrutinising such a quality piece of work, I'm picking on the maybe 1% query because the quality of it is so so useful. So yeah, it's a great point. As an overall overarching informative trial and practice, it's ideal. Sometimes we do nitpick, and some of the questions, I suppose, did that.
Yes.
Then.
I think it's certainly helpful because in some of the fields that I work in is primary care, which is not necessarily acute emergency injuries, but I also work in sport environments where I do come across those injuries. But some of the questions you do get thrown back in clinical practice is by some patients is, if I was a professional athlete, would you be treating me in the same way? And we've got this information now to say, well, actually, there are some options here that we could apply to you regardless of whether you're a professional athlete returning to sport quickly or somebody who just needs to be able to get to work and sit at a desk.
Yeah.
And post-operative protocols, procedures and policies remain commonplace across orthopaedic practice, although they're increasingly written as a collaborative MDT, most of which we've encountered seem quite generic with little scope for individualisation. We've kind of alluded to it earlier as to how these things get formed on long-standing assumptions. In research, there is a need for protocol-based proceedings, and that needs to be formalised to some degree. When that's then extrapolated into clinical practice, it seems that can be somewhat restrictive. How do you see that being better translated? Okay, so there was number one of two of our interview with Sallie, which I think we both admit starts to escalate and then get juicier and more controversial as it goes along. But one of the first things we talked about really in that was evidence and evidence integration, and speaking specifically to a revered clinical trialist who's doing these big pieces of work, and then us as frontline clinicians trying to get that implemented and applied. What were your thoughts on her opinions around that?
She certainly has some very strong opinions, and obviously they're well founded in experience and in what she does. And some of the trials that she runs are fantastic. They do give us a wealth of information. I felt sometimes that it was a little bit too polarized in the sense that it was lent quite heavily along a statistical point of view, despite us exploring some of those things. There was this sort of, what it boiled down to was, well, this is what the numbers show.
Yeah, and the variables that were untested therefore go undiscussed.
And that's got to be the case, hasn't it? We can't have a piece of work that has 20 different variables to measure. It's just the way it is. But it would be nice to have that acceptance that, okay, well, this is not a complete piece of work, and that if anything, maybe clinical trials should be run as a series. So that follow-up parts could be done along different avenues.
Yeah, and it grows and grows. Yeah, I think as well off that, it's a personal bias of mine to just cringe at the idea of us finding answers. I just think we should just find more questions. And although we get these tentative answers, we can't be hanging too much on them. For example, what is it about the cast? Is it the non-weight bearing? Is it the actual act of the compression? There's all sorts of other things, and although quite, this is not me saying that Sallie was hanging huge amounts on them. It was just that there's probably a bit of distance there, and I think I when I listened back, I cringed at some of my me chasing a question around and round, particularly around the cast trial, with what I was getting at with regards to the self-selection of weight bearing status.
I just don't think she got it.
No, and I think that might well be a fault in my question. But what I understand of research, which is far less than what, of course, she does, is what I know is resentful demoralisation. The idea that someone that is albeit randomised, still as a human, is going to favour both consciously and subconsciously a trial arm. And therefore the idea that the severity was measured clinically, which we both agreed with, which was fantastic, rather than radiologically. The idea that they were then going to hobble in there having, to some extent, they can't weight bear. So for someone to legitimise that socially and to say, okay, don't then, here's a cast. I was just sort of meaning that in the short term, could that influence the results? Because I'm completely comfortable with that idea of cast. I'm not going to be... I dislike the idea almost that the people that have criticised this trial go down the line of questioning thromboprophylaxis. Cause that's such a rubbish part of an argument that just simply, it's as if people are just trying to nitpick, and I didn't want us to come across like we were nitpicking.
No, you'd highlighted that as well in the interview, which I think I think it was good that it was said, because she certainly sort of resonated with that.
Yeah, because it's important. We don't want to be over scrutinous. It's just that, generally speaking, there's still so many questions. There's still so many eyebrows raised. I don't feel like that is a line of inquiry that has been exhausted by any stretch.
The difficulty is with statistics. Statistics for me appear very like the biomedical model. You want a cause and effect, a question and an answer, and then that's your job done.
And as sometimes that's ideal. Some walks of life, some parts of medicine, it's perfect.
Yeah, exactly.
We work in more complex cases than that, and I would say a severe ankle sprain is just that, a much more complex case with a much more complex situation. And I've all sorts of things have cropped up since that chat, just because we had to move on, and we covered as much ground as we could in the time we had with her. But generally speaking, there's all sorts in there. I mean, you can't swim or cycle in a cast. Mm-hmm. You can't. It's just like there's
can't drive.
You can't drive in a cast. There's all sorts of things, all sorts of permutations that make me just think that really and I'm not doubting that there's other people that are working within that industry of being a clinical trialist that aren't also having these thoughts. Don't get me wrong, but it's just the thing that makes me think that physiotherapists' role within trials could be far more than statistical scrutiny or just from fulfilling a role. It could be to present those things throughout the construction and the methodology of the trial, almost preempting the problems that the research might find and face.
Yeah. So when somebody's reviewing it prior to publication, these are the things they should highlight as, that now more recently in the last few years, researchers kind of putting summary boxes at the start and at the end of articles. That kind of thing, a little pause for thought at the end would be ideal.
For sure. So the conversation escalated, and we got some juicy stuff on the MINT trial, where her work with very high N numbers had been suggestive that physiotherapy doesn't influence the course of whiplash recovery. So that's something to look forward to for the next episode, right?
Oh, definitely. Yeah, that's going to be a conversation starter online.
And that was session 23. As if it was ever in doubt, it turns out if me and Rob are presented with a load of research, that we end up turning it into a journal club. So I hope you've enjoyed our little summary at the end. And so to wrap this one up, get following at Physio AOCP on Twitter, and I can announce that as of their annual conference in a few weeks' time, the network will be adding trauma to their title, and so will be the ATOCP, a brilliant set of forward thinkers who I'd hugely recommend getting involved with. Visit www.aocp.csp.org.uk, and if you want one of the last few spaces at their conference on the 21st of November, quote TPM Podcast when emailing them through their website for a whole day CPD for £50 if you're a member and £70 if you're a non-member, so definitely well worthwhile. We'll be back next month for our year's finale, and possibly our most controversial debate yet. And to finish, here's David Keene to see us out.
You've been listening to the Physio Matters Podcast, discussing physio matters because physio matters.